Hi, everybody. Welcome to Handling Multicultural Issues in the Therapy Room. I'm really excited to be back with Agents of Change and to be offering another presentation. I had also presented about military children and families, both by myself and in conversation with Bonnie. So if you're interested in those topics, please do feel free to check that out. Here is a little bit about me. I am a licensed clinical social worker. I've been a social worker for nearly 17 years at this point. I have trained in a variety of different kinds of therapies, primarily cognitive behavioral therapies, but I also have some training in other therapies as well. I work with kids and with adults and with families, and I am currently in private practice. If you're interested in connecting, my contact information is at the end. And I am really excited to be sharing this presentation with you. We're going to start out with the introduction with the light bulb because it's full of bright ideas. Okay, first things first, let's think about what culture is. We'll be starting there. We also are going to be talking about behavioral health culture in comparison to other cultures like general Western culture, military culture, things like that. We'll be spending some time talking about intersectional identities, demographics, and who you may be seeing depending on your setting and depending on your context, and what to do when these kinds of issues pop up, because they will. The main things that I want you to take away from this presentation are that this is hard work, and so I don't want you to be doing it alone. I really encourage everyone to become educated about cultural competency issues. This is ideally done in community with other people. This could be something that you do with other therapists. It could be something that you do with friends, family, just other people you know. Remember that learning is a continuous process, so do stay curious. I want to remind you that we don't learn things all at once, as you know, because you are watching this and therefore you probably have a lot of formal and informal education. Know that you're going to make mistakes. Language and culture evolve and change, and definitely try to maintain a growth mindset rather than a fixed mindset. That's going to be a big help. There is a lot of information on military culture here, and you may be wondering why that is. This presentation is adapted from a presentation that I gave while working at an outpatient behavioral health clinic helping veterans and military family members. I did keep in some of the information about the military because I thought it might be useful for anyone who is newer to working with this population or just anyone who's curious. First, we're going to be talking about culture and cultural diversity. Culture is our lived experiences that impact our worldview and our perceptions of others. Culture is a shared experience among people. It may include common language, norms, and models for values, behaviors, and beliefs. Military culture, mental health culture, Western culture, lots of different cultures are going to be relevant as we're thinking through this. There are a few things to consider when it comes to cultural expectations in general. We always want to practice cultural humility, aka the idea that no matter what's going on, you're never fully going to be able to get somebody else's culture. Even when we do share other people's identities and cultural backgrounds, we may have dramatically different experiences, and I do want you to keep that in mind. Also, remember that you do want to know your own values. What you value is going to influence what you pay attention to, what you're interested in, what comes up for you as you work with people of different cultural backgrounds and as things come up clinically. Do your homework, become knowledgeable about who you're serving and learn the lingo, whether that's military or otherwise. Maybe you're working with teenagers and you are older and so you don't necessarily know what they're talking about. You can surreptitiously Google if you are on telehealth, but you want to learn what people are talking about, whether that's because they work in a specific industry, because they come from a different background than you, whatever's going on. Try to learn. Don't assume, and do ask questions that are clinically relevant and clinically appropriate, both for your context and for the relationship that you have with your client or clients. Okay. I have a few videos that I sprinkled into this presentation. This is the first one. Dr. Bryan is a psychologist, and she talks about having a more holistic perspective on psychology. I really liked this video, and I thought it was a nice introduction to thinking about cultural competency and cultural humility in the context of our clinical practice. So take a look at this video, come back, and we will pick up when you are. Workplace culture matters too. So workplace culture and roles in the workplace do have an impact on how cultural issues show up. So this can be where your client works. This can be where you work. The setting that you work in is likely to have an influence on how you work with your clients, and it'll affect who you see or who you don't see. If you work in a community mental health center, you are going to be seeing different people versus if you work in a university health center, which might be more socioeconomically diverse, or if you work in a private practice. There are a lot of different things that you want to consider when you're thinking about culture. We want to consider age, race or ethnicity, gender identity, sexual orientation, socioeconomic status, including class and level of education, language. Is somebody's native language English? Is their native language something else? What sort of language do they speak at home? What language did they grow up speaking? Ability or disability status, this impacts how people navigate the world and the experiences that they're likely to have, as all of these do. So it's really valuable to consider some of the nuances and how all of these fit together. You also want to consider somebody's health status. Somebody who is generally in good health and somebody who doesn't have to interact with the healthcare system frequently is going to have a different experience with you versus somebody who maybe has some chronic health issues going on, especially thinking about other factors like age, gender, race, sexual orientation, levels of privilege, things like that. We want to think about somebody's history of traumatic experiences. If someone has had a lot of trauma and you are not trained in providing trauma-informed care, they might not have the greatest trust in you versus if somebody has had trauma and you make it really clear that this is something you're comfortable with and you offer a trauma-informed perspective. We also want to think about what somebody's legal history is. Has this person had personal experience with being arrested, being incarcerated? Have they had encounters with law enforcement? What's that like? And how might that show up in your clinical work? Citizenship and immigration status, of course, this is a big thing. I think particularly as I'm recording this right now in 2026, this is something that can make a big difference in the experience that somebody has with you and their sense of trust and safety. Where somebody lives and where they grew up will have an impact on their culture and their personal experiences. Somebody's relationship status, hobbies and interests, work background, and identification with their job or their career, professional status, things like that. Religion or lack of religion, and then identification with different cultures as may be connected to personal identities. I will be talking a little bit about LGBTQ culture and neurodiversity culture later on, in case those are things you're wondering about. Okay, next we have another video. Some of you may already be familiar with the concept of adverse childhood experiences. That's what ACEs are. The video is going to give a little bit of information about how adverse childhood experiences and trauma affect people's health. I just think that it's good to keep in mind that even if something happened a long time ago, there still can be a long-lasting impact, especially for anybody who experienced complex trauma as a kid. Okay. There are a lot of different reasons that somebody might have experienced trauma, and we want to think broadly about trauma. The concept of big T and little t trauma is one that you may have heard before. We know that there are a lot of reasons that somebody might be vulnerable to trauma, and one of those could be neurodiversity. It could be other marginalized identities that somebody might hold. A lot of our clients, especially if you are working with folks who are underprivileged or historically marginalized, have multiple marginalized identities, whether we're talking about socioeconomic status, race, gender, sexual orientation, and more. Navigating oppressive systems can increase somebody's experience of stress, especially if it's something they need to do regularly. For example, accessing physical and mental health care. I really liked this graphic, which is why I chose it for this particular slide. This is a wheel of power and privilege, and it starts in the middle with somebody having more powerful or privileged identities, and then moves out to the edges as somebody has more marginalized identities. And it talks about different kinds of privileges that someone may have or lack based on health status, based on ability, based on education, financial resources, housing status, things like that. So take a look at this and see where you are on the wheel of power and privilege, where some of your clients might be on the wheel of power and privilege, and just take some time to think about that. Speaking of things related to power and privilege and intersectional identities, I found this really great video series a number of years ago from Emily Chen called Disorient. She specifically has a video about moving beyond neurotypical thinking. And so this video is about acknowledging Asian American experiences of neurodiversity. I really liked it. I think that the way that she presents things is really accessible and interesting, and I definitely encourage you to check it out too. Okay. I know I just used the term neurodiversity without defining it. Don't usually like to do that, so here we go. Maybe you've already heard this term, and maybe you're like, I'm already very familiar with neurodiversity, Mattia, which is great, and go you for being educated. Some people may be newer to learning about this, so I did want to talk about it. The term neurodiversity is used as a broader term to understand what it means when somebody's brain works differently from expected. Neurodivergent describes one person. Neurodiverse describes multiple people at once. The working definition that I use here is that someone is neurodivergent when their brain works in a different way than what society expects, and this difference causes challenges for them. So this could be somebody who is an adult or a kid going to school, and they think about things in a different way, they learn in a different way, and they don't get such great support or positive reinforcement for that. It could also be somebody who is neurodivergent and their experience at work doesn't really match the accommodations or expectations that they need to be able to thrive. Neurodiversity is a pretty big umbrella now. The term originated within the autism community, and it has since expanded to cover lots and lots of different kinds of brains and different ways of understanding ourselves. Some of the diagnoses, I guess, but conditions maybe is a better way to say it. Some of the conditions that might be included in the term neurodiversity are autism, ADHD, or attention deficit hyperactivity disorder, ADHD. This is a newer term for when someone has both autism and ADHD. Dyspraxia, so differences in movement. Dyslexia, somebody who has difficulties with reading. Dyscalculia, difficulties with math. Dysgraphia, difficulties with handwriting. Synesthesia, this is not really a disorder per se, it's more like you have a different experience with your senses, so you might have multiple different kinds of sensory input at once. So things like hearing colors or seeing sounds, things like that, having associations between a particular number and a particular color, or a particular letter and a particular color, things like that. Twice exceptionality. I don't know how old this term is. I learned it within the past few years, so it's relatively new to me. Twice exceptionality is when somebody has deficits in some areas and strengths in others. So this could be somebody who has ADHD and maybe doesn't have the strongest executive functioning, but they're also really bright and they're really creative and they're good at solving problems. So they are on two different points on the bell curve. Learning disabilities, I listed a few of these earlier, but there, of course, are other learning disabilities. And then sensory processing differences, just because, again, this is a sensitivity and a different way of somebody's brain working. Neurodiversity and LGBTQ identification have a higher amount of overlap than you might expect. And I wanted to talk a little bit about that, just because if you work with one of these populations, you're very likely to see the other two. Folks who have non-cisgender or non-heterosexual identities are 3 to 6 times more likely to have an autism diagnosis. Gender diversity is more likely associated with autism than with not having autism. Up to 70% of people with autism identify as LGBTQ+, meaning that they would say that they have some sort of non-heterosexual orientation. Autistic adults are more likely than allistic or non-autistic adults to identify as asexual, aromantic, or both, which I think is really interesting. There are higher rates of ADHD among queer-identified individuals, and there also are higher rates of bisexuality in ADHD populations. Now, these don't cause each other, but they are correlated. Okay. You may be wondering why there's so much overlap, and I think it is an interesting question. There are a variety of reasons, and we don't fully have an explanation exactly, but it's good to keep all of these factors in mind. So one is that as a result of neurodiversity, someone may experience greater challenges with social and cultural norms, and as a result of that, they may be less likely to adapt to norms and then more likely to question or explore outside of these norms. Abstract reasoning, creativity, and out-of-the-box thinking may all contribute to greater curiosity and interest around gender and sexuality. Feeling alienated from neurotypical norms can lead to people feeling like outsiders and therefore having more openness to alternative gender and sexuality, including a desire to have community that feels inclusive and promotes a sense of belonging. Neurodiverse individuals may also feel sensory or emotional stimuli more deeply, which can lead them to explore sexuality more than their neurotypical peers do. Neurodiverse groups often include LGBTQ+ community members, which can lead to greater access to and awareness of queer community. Now, doubly marginalized identities can reinforce each other. We also know that LGBTQ identity and neurodivergent identity don't cause each other, they're just correlated. Remember from Psychology 101, correlation does not mean causation. Okay, here's another video. I thought this was a really great watch. This is from a number of years ago, so I'm not sure if there have been changes in terms of his military career, but Keith Nolan talks about being deaf and wanting to join the military and what happened when he tried to do that. So he is signing in this video, and then the interpreter is speaking. The interpreted translation of what he's saying. I really liked this video, and I think it's a nice reminder around intersectional identities, even in the military. Okay, here's some information about mental health and military cultures, which, again, you may be familiar with this already, or this may be newer for you. Traditional mental health culture is very individually focused. We have the one-to-one model for sessions that's most common, so meeting with one client for individual therapy. There's an expectation of individual work being more emotionally vulnerable in a mental health context. Typically, mental health work is individual therapy, though of course there also can be couples work, family work, and group work. Mental health culture traditionally has assumed deficits and illness, especially in the medical model, rather than focusing on strengths. And there's an emphasis on symptoms and risk factors. On the other hand, military culture is more focused on the collective and on the group. There's an expectation of emotional toughness rather than emotional vulnerability. There's an idea of the group mentality promoting safety. There's a saying that I learned when I worked with veterans, got your six, forgot your back. It's because of where the numbers are on the clock. So 6 for behind you. And there's an assumption of strength and power in military culture. There's also an aspect of the warrior mentality and specific skills that are learned in military culture to help promote safety and the military goals. I skipped one slide ahead. Oops. Okay, some extra information about military culture that I think is good to know. When we compare military cultures with behavioral health and healthcare cultures, it is the case that military culture is significantly more socially conservative. So definitely keep that in mind. I didn't talk about guns on this slide, but I did want to mention that if you are working with this population, you do need to learn to get comfortable talking about that because it is a big thing. And especially if you're working with kids and with adults, you can talk about it in the context of safety. Like, oh, do you have any firearms at home? How do you store them? Do you need gun locks? If you're working with somebody in person and you can offer gun locks if they need them, I think that's great. It shows a level of knowledge and understanding. We gave those out sometimes when I was working at the military family clinic. And you just want to make sure that you show that you are up to date on the culture. Transition is a really, really big deal in military careers. So when somebody is transitioning out of the military, it could be that they are retiring after 20 or more years of service. It could be that they are transitioning because they're leaving medically because they're not able to do their job. It could just be that it's the end of their contract. Please be aware, many veterans don't have the support that they need in transitioning out of the military. And so they might need your help getting connected to resources for finding civilian employment, healthcare, housing, etc. Another thing that's a really big deal in military culture is the role of the trailing spouse or trailing partner. And how this affects military families. If you're interested in learning more about this, I definitely recommend checking out my other presentations, but I'm going to touch on this a little bit now too. Military families do relocate more often compared with civilian families. And what that means is they might be separated from their social support systems, whether that's family, friends, community, etc. So it can lead to some really big issues showing up. Childcare, which we know is not affordable in the United States the way that it needs to be so that families can have the support and the resources they need. It also might be the case that the spouse or partner is experiencing unemployment or underemployment. If you have to be licensed to do your job, like a mental health professional, like another healthcare practitioner, you need to be licensed in the state where you are living. And that can create all sorts of problems financially and otherwise if somebody wants to be working and can't. You may be familiar with the interstate licensing compacts. Some of them have progressed more than others, and this can be a really, really big deal for military families. Imagine that the military spouse is moved from one duty station to another. They have a permanent change of station and they're in a new state. Now the spouse needs to A, find a new job, and B, be up to date on their clearances and licenses so that they are able to work at that new job. So this creates a lot of really big problems for military families that you wouldn't necessarily know about if you hadn't taken the time to learn about it. Also, schools, healthcare systems, and communities are often uninformed or underinformed about the unique experiences of service members, veterans, and military families. So by educating yourself, you can play an affirming and supportive role in someone receiving the kind of services they need. Even just asking, did you or a family member serve in the military, can help show that you are interested in somebody's experience. Again, if you're interested in learning more, definitely check out my other presentations. Okay, now actually back to this slide. Demographics. In this section of the presentation, I'm going to be comparing the general United States population to the behavioral health provider population, considering gender, age, race, and level of education. There's also a little bit about economics and income, but I don't have as much data on that as I would have liked. Okay, gender. Looking at the adult population in the United States, it's over 267 million people, about 49% men, about 51% women. Interestingly, in the therapist workforce, it is really not gender balanced in a way that is proportionate to the adult population in the United States. And there are a variety of reasons for that I'm not going to get into, but I will invite you to think about why that is. The therapist workforce is about 70% female, almost 25% male, and about 5% unspecified. So unspecified could obviously be that somebody didn't choose to report their gender or that they identify with a different gender. We don't really have a lot of data about non-binary and trans identified folks in the psychotherapy workforce, just because the census doesn't have a lot of data on it, and there isn't a whole lot of information about this. Unfortunately, there does need to be more research, and we do need more data. Okay, age. Breaking down the whole population in the United States, that's over 340 million people. Looking at the adult population only, we have things broken down by age cohort. So we have 18 to 24, 25 to 29, all in little 5-year increments until we get to 65 plus, because we're a bit less interested in understanding nuances of people outside of the workforce for this specific population. Okay. Most of the little 5-year brackets are pretty even. The biggest ones are obviously 65 plus, 18 to 24, and 30 to 34. So when we think about who is in the adult population, obviously some of that just varies based on when people were born and what was going on at the time that led to either a higher birth rate or a lower birth rate. Looking at therapists are not really very representative of the whole age range of adults. According to the survey that I had found, almost 15% of therapists are 20 to 30, which makes sense because you have to go to at least a few years of school beyond undergrad, whether that's 2 years for a full-time master's or 3 or 4 years for a part-time master's, and then maybe 5 or 6 or even more years for a doctorate. So it makes sense that there aren't that many therapists in that younger age range. Then we have 34% in the 30 to 40-year-old range. And then more than half of therapists are over 40, which is interesting. And I hope that we do have new therapists coming in, because of course the need is very great, but I think there have been so many different changes in the workforce and in what it's like to work as a therapist that it might make sense that people are making different career choices. Okay, race and Latino origin, again, looking at the US population, it is mostly white, and then so 74%, about 12% Black or African American only, about 0.8% American Indian or Alaska Native, about 6% Asian, about 0.2% Native Hawaiian or other Pacific Islander, about 5% other race only, and about 2.3% 2 or more races, and approximately 16% for Hispanic or Latino of any race. So if we look at the racial and ethnic composition of therapists, some of it is proportionate to the adult civilian population and some is not. Like white therapists are a bit overrepresented, Asian therapists, interestingly, are also a bit overrepresented. Hispanic or Latino and Black or African American therapists are underrepresented, unspecified, we don't know. And American Indian or Alaska Native, underrepresented. Then we have psychologists compared with other therapists. I'm not entirely sure why the survey did break this out, but I do think it's interesting information. So again, white therapists are overrepresented here. Hispanic or Latino therapists are underrepresented. Black or African American therapists are really underrepresented. Asian therapists are underrepresented, unspecified or unspecified, and American Indian or Alaska Native are also underrepresented. Okay, this was really interesting to me looking at the level of education piece. So if we look at the adult population in the US 25 plus, just a little bit over 11% of this population did not complete high school. And so we have about 4.6% achieved less than a 9th grade education, and then about 5.5% 9th to 12th grade. A bit over 25% graduated high school or completed the equivalent, so probably a GED. 18.5% some college, 8.8% associate's degree, bachelor's degree, about 22%, and then graduate or professional degree, which is going to be most of what we think of when we think of therapists, about 14.7%. Now, I was really surprised by some of the information in this particular survey about therapists, and I'm wondering who they were surveying, because this is a bit unusual given the experience that I have working in different settings. So what they found in the survey was that 47% of therapists had a bachelor's degree, 42% had a master's degree, 6% had an associate degree, 2% had a doctorate degree, and 3% had some sort of other educational attainment. I'm really not sure what's up with the bachelor's degree and associate degree and the other, to be honest. But my guess would be that different states and different jobs have different requirements in terms of credentials. I never have seen a significant proportion of jobs that are saying you don't need to have a master's degree or you don't need to have a degree. That feels to me like not setting potential clients or people receiving services up for success, but I don't know. All right. This was interesting to me as well, looking at income and class. So looking at all the total households, we have over 132 million households, and then the income brackets are under 10,000 and then broken down for the most part in relatively small increments here too. So looking at this, the pay for mental health professionals is pretty variable based on job, based on geographic area, based on specialty, and of course, based on degree. So if we look at where people fall, most of the master's level mental health professionals' earnings would be below the median household income and certainly below the mean. Thinking about our averages again, we know mode is the number that is most frequent, and an average mean is what you would get if you averaged all of the data in your data set, and median is if you lined up all the data in your data set, what's in the middle. So despite the fact that most mental health professionals have at least a master's degree, people are not really earning very well for that, except if they're psychologists or except if they have some sort of specialized expertise. Okay. Also, there are differences in educational level for therapists that affect income, as I was talking about before. So weirdly, the bachelor's degree and the master's degree do not pay that differently, which is strange. You would think. There was a recent Washington Post article that I didn't cite where they were talking about the value of additional education, and they basically said a social work degree does not pay off, and then people started freaking out in the comments and saying, well, that's maybe not the right way to look at it. At any rate, I don't really understand why the master's, bachelor's, and doctorate income differences were so similar in this particular study, but I do think it's weird that sometimes people think there's a high level of status associated with working as a therapist, but a lot of people are not really earning that much. And some of that relates to systemic issues in the labor market, including use of contractors instead of employees, and not offering safe and stable jobs because of it being kind of a feminized kind of work. I don't want to get into that too much, but I do want to just point out that that is a thing, unfortunately. Okay. I wanted to touch on urban versus rural populations a little bit, just because I think it's interesting and I think that it's relevant for culture. According to the 2020 United States Census, 80% of the US population lives in urban areas, and then 20% of the population lives in rural areas. Over time, the population has become more and more urban. So urban areas have become more densely populated over time. And clients who live in rural areas may experience different stressors or similar stressors to clients living in urban areas. This can include social isolation, poverty, food insecurity, lack of insurance or underinsurance, difficulties accessing healthcare, and a social and cultural context that may not be well understood by their healthcare providers. Unfortunately, a lot of rural healthcare systems and hospitals have not gotten the financial support and resources they needed to be able to continue serving the folks that they see. And so many people living in more rural areas may be more dependent on telehealth or virtual healthcare services than people living in urban areas who are more likely to be able to access healthcare in person and to have access to more specialized healthcare also. Okay. I think this is interesting. The 10 largest urban areas are the New York, Jersey City, Newark, New York metro area, the Los Angeles, Long Beach, Anaheim, California metro area, Chicago, Illinois, and the associated Indiana metro area, Miami, Fort Lauderdale in Florida, Houston, Texas, Dallas, Fort Worth, and Arlington, Texas, Philadelphia, Pennsylvania, along with New Jersey, Delaware, and Maryland. In the Washington, D.C. area, we have Washington, D.C., Arlington, and that covers D.C., Virginia, and Maryland. Then we have Atlanta, Georgia. And last but certainly not least, for our 10 largest urban areas, we have Boston, Massachusetts, as well as parts of New Hampshire. Okay, so let's think about the demographics overall. When we compare our therapist population to our client population, therapists are older, more likely to be women, more likely to be white, in general, less likely to be people of color, so less likely to be Hispanic or Latino, less likely to be Asian for psychologists, more likely to be Asian for therapists generally, less likely to be Black or African American, and about as likely to belong to other racial groups such as Native American, Alaska Native, Native Hawaiian, other Pacific Islander. And also therapists are more educated than the general population, so therefore more educated than client populations, though of course, depending on who you see, this may vary. You may have noticed that I didn't include data about sexual orientation. That's because the census doesn't currently collect it. Although I did see when I was looking at some of the data for updating this population that there are now more same-sex couples living together now than about 20 years ago, which is not terribly surprising, but still interesting. Okay. I live in Philadelphia, so we're going to take a close look at Philadelphia demographics, and then I'm going to encourage you to do the same learning about your community or communities, where you live, where you work. As of July 1st, 2025, the total population of Philadelphia was a bit over 1.5 million. That's 5.8% of the population under age 5, a little over 20% of the population under age 18, about 15.4% over the age of 65, and about 52.8% female. Veteran status from 2020 to 2024 was about 46,015 people. 87.8% of adults 25 or older have at least a high school graduation or higher, so a diploma or a GED, and then 35.4% of adults over the age of 25 have a bachelor's degree or higher, so Philadelphia is more educated compared to the average. About 15.2% of Philadelphia residents were born outside of the United States, and looking at race for Philadelphians, about 44.4% white, 42.4% Black or African American, 1.1% Native American or Alaska Native, 8.7% Asian, 0.2% Native Hawaiian or other Pacific Islander, 3.2% two or more races, and then 16.4% Hispanic or Latino. Okay. I hope that you can see these maps. I wanted to put all of them on one slide because they tell a really interesting story. So let's talk first about the little map in the lower left-hand corner that's talking about redlining. If you don't know what that is, redlining was a historic practice by banks to decide that some neighborhoods were desirable and some neighborhoods were not desirable in terms of investing in them, issuing mortgages, things like that. And this is based on racial classification and the racial makeup of the neighborhood. So if we look at that map, that's the information about different neighborhoods that were considered to be desirable versus undesirable. And if you then look at the blue map, the lighter the blue, the more walkable the area is, and the darker the blue, the less walkable the area is. So where it says Philadelphia in the middle is downtown. Downtown Philadelphia is extremely walkable. And as you branch out to other neighborhoods, some of them are still walkable, but some of them are not. So that huge dark blue section in the bottom is Southwest Philadelphia, which includes the airport, which is a very unwalkable neighborhood of Philadelphia. And some parts of the city are changing. This is a relatively recent map, but I would say that there has been some investment in trying to make neighborhoods safer, greener, more walkable. And if you look at the third map with the street image and the property values, you may not be able to see it because it's very small. What that represents is how much per square foot properties sell for. And all three of these maps are very similar. So I think even though they're representing different things, what they're essentially saying is different neighborhoods are considered to be more valuable or less valuable based on who has historically lived there. And I think that it's worth us considering the neighborhood context and the community context when we think about our work, when we think about our clients, when we think about the systems around us. So I hope that you'll take a look at your neighborhood and your community and get to know the history too. Similarly, here's some information that's Philadelphia specific, but the concepts might be things that are useful for you to look at wherever you are, because probably you're not all in Philadelphia. You can look at maps and data to learn more about where you are, whether that's looking at different city infrastructure, things like parks, recreation, hospitals, SEPTA stops. SEPTAs are public transit, bike paths, schools, farmers markets, library branches, crimes reported, vacancies, business violations, lots of information to understand what is it really like in different parts of the city. And I think that especially if you see people who live in neighborhoods that you haven't been to or that you haven't been to recently, this is a fast way to get some information about what it might be like to live in that area, particularly if you see folks over telehealth who live in places you've never been to. The University of Pennsylvania has policy maps that give information about demographics, income, housing, lending, quality of life, the economy, education, health, and other indicators that give us information about what it might be like to be in a particular area. Walkability, which I had talked about before, the Walkshed website gives information on that. The City of Philadelphia Stress Index shows a variety of different stressors, including things like asthma, drug crimes, heat stress, distance to parks, access to healthy food versus being in a food desert, median household income, poverty, unemployment, education, and more. What about your community? You can learn about the privilege that exists in your community as well. Thinking about literacy rate of graduation from high school or equivalent, rate of college graduation, what are the average tax brackets, what religion or religions are dominant, percentage of queer or trans people living in your community, the police budget and the homicide rate of minority-owned small businesses, so who are the small business owners and what are they like demographically relative to the rest of the community, what is the refugee population in your community, how prevalent is homelessness and what resources exist to help people who are unhoused, what's the budget for infrastructure, what percentage of urban tree canopy exists in your community, is that something that is more available in certain parts of the community than others, how walkable is your community, and what's the voting rate in your community. You also want to think about integration versus segregation. Is your community more racially integrated? Is it more economically integrated, or is it more racially or economically segregated? What parts of your community were impacted by redlining? If you're interested in learning more about the concept of redlining and how law interacts with race. I definitely recommend reading the book, The Color of Law. It's really good. I don't remember the name of the sequel, but there is a sequel about updated policy information. So really, really good stuff if you're curious to learn more about how policy affects your community now and how it did in the past. How are your local schools rated? What sort of things are people saying about the institutions in your local community, like the schools? In your community, do people have reliable access to clean water? And what are the most prevalent political affiliations in your community? And how does that affect what happens in your community or what does not? In mental health practice, we really want to approach things from a standpoint of cultural humility, aka the idea that we can't fully know or understand somebody else's culture. There is a difference between cultural competence and cultural humility. So cultural competence is like, I understand other people's cultures. I have taken the time to learn about it, but cultural competency is not the same as cultural humility, which is more like I am engaging in a continuous learning process around understanding other cultures that are not my own. Related to this, because this is hard work, I wanted to share a video from Brene Brown about empathy. This is short. This one is only a few minutes as opposed to some of the other videos that I linked. I like the difference between thinking about empathy versus sympathy, acting with compassion. Definitely check this one out too. I think you'll like it. Okay. In terms of guiding principles for cultural competency, these are from some more official guidelines rather than just things that I came up with. We want to think about ethnicity and culture as universal. We want to think about cultural competence, as I discussed before, understanding different cultures and how there might be things that we can know in general, but that we always want to get to know the specifics of our clients' unique experiences and not expect that they will educate us rather on their culture, but that they'll educate us on how their culture affects them specifically. We want to consider social and environmental influences, so broader factors that may be around people. Consumer-driven services, so having things set up in a way that is client-centered and respectful. We want to think about what the system of care looks like. How can people access care that is culturally competent and appropriate for them, regardless of what culture we're talking about? We might be talking about race, we might be talking about gender, we might be talking about economic status, lots of different factors when we think about the systems of care. We want people to be able to access the care that they need, where and when they need it. We want to think about quality of life outcomes. How is the healthcare that somebody's receiving helping them? We want healthcare systems that are integrated and that are coordinated so that if you see a provider at your local hospital system and then you see somebody else in the hospital system later, they can talk to your other provider and say, oh, I met with so-and-so and here are my concerns, rather than having a healthcare system where people don't talk to each other. We want data evaluated and data-driven systems of care, so using the information we have to do what's most effective. We also want to offer services that are the least restrictive or least intrusive, given what is needed and what is appropriate. Okay, getting into more of what you are likely to see, I wanted to talk a little bit about boundary issues that might pop up. If you are in the field for long enough, you are going to have people asking you questions that maybe you don't want to answer. So it's helpful to think about this in advance for what you would say. And it's really helpful to talk with a trusted supervisor or a trusted colleague to think through how to answer these questions. So I have some examples. You may or may not get these particular questions and you may or may not feel comfortable or prepared to answer them. So I just want to put it out there as things that you want to consider. If you are working with veterans or other people who come from cultures where asking a lot of questions or wanting personal information might be more commonplace or accepted, You are very likely to get some of these questions. Do you have children? Are you married? Did you serve in the military? Are you going to take away my guns? Have you ever experienced particular trauma? Are you a member of a specific religious group? Are you a member of particular political party or particular political affiliation? Know what your boundaries are and think in advance about how you would answer these questions so that you're not caught off guard. I also would like to point out that if you work with kids, kids will ask you questions that adults wouldn't because they have a different filter. And so kids will ask you questions about things that you might not be expecting. So just keep that in mind. Here are some examples of things that might pop up, and I just want you to think about how you might handle them. If we were in the same room and we were having a conversation about this, we might do some role play or exploring around this, but since we're not, I just want to throw these things out there as possibilities. Let's say somebody uses a term that you don't know. Maybe it's a military term, maybe it is a kid using some sort of slang that you haven't heard of. Maybe they are using some sort of term that you just haven't heard before. What would you do? Would you ask them what it means? Would you surreptitiously Google that if you were on a telehealth appointment? How would you handle it? Maybe you'd ask them about it. Maybe you'd ask a colleague about it. Just think about it. Also, unfortunately, because it's 2026 as I'm recording this right now, and I don't foresee this changing immediately, there is a lot happening in the news. So it is very possible now in a way that maybe wouldn't have been the case, say, 10 or more years ago, that there's something happening in the news and it's coming into your office. So maybe there's some sort of police violence, maybe there's some sort of political event, and your client wants to talk about it. And maybe you're really up on the news, or maybe you are not really up on the news because it's stressing you out. Just be aware that this is very likely to show up in your office, whether you want it to or not. It's also possible that your client might say something that you think is offensive. Maybe they say something that you think is racist or that sounds sexist. It seems xenophobic or homophobic, transphobic. Could be that they say something kind of offhand that reads to you as Islamophobic or anti-Semitic. Maybe your client says something that seems kind of ableist or ageist, classist. Know that this is likely to happen and that you are going to be best positioned to handle these types of things if you've thought about it before and if your needs are met so that you are able to respond with curiosity and calmness rather than judgment. Cultural differences in the therapeutic relationship. This is a really big deal. And I think that not everybody learns how to deal with this in grad school. So know that this will happen, that you will be seeing clients who come from different cultural backgrounds than you. And it's good to be comfortable addressing this. Maybe in your informed consent, you say something like, it's really important to me that our work together is valuable for you. And I know that there can be differences between us that might get in the way. If that ever happens, I want you to know that I really care about your feedback and you having a great experience in our work. So please do tell me. And also, if you notice that something's going on, you can consult with a supervisor or trusted colleague and bring it up so that it doesn't interfere clinically. The big takeaway that I want you to have from these case examples is that these issues are present whether you talk about them or not. So you really do want to be thoughtful and careful about setting up a culture of respect and openness early in your clinical work, because that's going to make it more likely that you can have those important and challenging conversations. In different settings that you may work in, you'll likely see different things in the client population that you serve. So if you work in community mental health, if you work in a hospital, if you work in a university system, if you work for some sort of nonprofit, if you work in private practice, what you see setting to setting, job to job, will be similar or different depending on your context. Depending on where you work, you may see clients who are uninsured or underinsured. You may work with clients who are underemployed. Your clients may be less knowledgeable about the healthcare system or behavioral health care. And very likely, especially if the other bullet points apply to your clients, they are dealing with multiple different stressors, not just issues with their mental health. Okay, I have one last video to end with. The title of this video is Get Comfortable with Being Uncomfortable. And I think that that's a really good motto for thinking about addressing cultural issues that can come up in therapy, because we know that this will happen, and with practice it'll get easier and you'll be able to feel more confident and prepared in your ability to handle this. There also are many great resources out there to help with educating yourself, whether it is some sort of book list on dealing with different kinds of isms or taking a class, things like that. I really encourage you to look and see what's out there, because if this is something you want to work on, lots of people want to help you, even now. Okay. I would ask these if we were in person too, but since we're not, I'm just going to allow you to reflect on them. In the future, please think about what support you need to continue doing this work effectively. Do you need to have a regular consultation group where you talk about cultural issues in therapy? Do you need to be earning more money so that you can take more time off and do more trainings? Do you need to carve out time so that you are able to read new books and read old books and listen to podcasts and watch videos and take continuing education trainings so that you can do this work? Think about what you need and what needs to change so that that's possible. Also, ask yourself, what personal and professional communities are you a part of that are going to help you grow in cultural humility and supporting multicultural populations in your therapy practice? And then, always a good question to ask, how can you stay curious in your work so that you can continue to do this work for many years? Therapy can be really rewarding and really hard. And I know that it's not the easiest time right now. And I want us to have all the great therapists that we can. We do really important work, and what you're doing matters. I have a lot of references for this presentation. This is slide 1, and this is slide 2, additional references. Not everything is cited as clearly as I would like, because again, this is an old presentation from a number of years ago, and I don't have all the citations I originally used. So this is the information I have. And then last but not least, thank you. I'm really glad that you joined me for this presentation. I hope that if you if you have any questions, please do feel free to be in touch. My email address is mattia.lewitt@philadelphiasocialwork.com. Thank you so much, and I hope you have a wonderful day.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post-test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.